insulin resistance blocks you from weight loss. Insulin resistance will drive up blood pressure. It causes thickening in the arterial wall. It will cause a raise in your LDL cholesterol, which is a proxy for the problem. So we see LDL going up, and so that's why people want to treat it, but it's not the cause. Why do people get insulin resistance? Well, they get it because when I started looking after patients during the pandemic, I noticed the prevalence of metabolic disease. Almost everybody was obese or had type 2 diabetes, or at least had one other significant metabolic disease. But on principle, I felt this was really wrong, that people should have to take a vaccine, where the evidence was really equivocal as to whether there was any benefit at all. We really don't know, but there's a lot of concern about whether the vaccine has driven lots of autoimmune problems, what people are calling turbo cancers, what people are having sort of neurological deficits from, as well as some of the immediate problems that we saw early on.
Dr. Steve James, can you start by telling us what is the mission that you're on?
The mission that I'm on, quality of life matters for everybody. I think there are many different routes into quality of life and many obstacles in the way to obtaining that. For me, my personal mission is what I'm trying to do in my work and my general life. And that's to be a present human being who can enjoy his own life, bring something meaningful into the world, have good interactions with other people, look after them, and enjoy the curiosity that I've got.
And how is it that you're doing that in your day-to-day life? So what does that look like?
That looks like trying to be aware of what's going on, trying to be aware of the choices that I'm making. So who am I with? Where do I work? What do I do for a job? What do I eat? How do I connect to myself? How do I connect to nature? How do I connect to other people? How do I have a good life?
And then how are you extending that then to others and helping others do the same?
So I've got experience in health and medicine. And although I spent the best part of 20 odd years helping to run a Buddhist meditation charity, and I thought that was the best way to help other people, I now see that what's right for me now is to use health as a vehicle for people. And by that I mean, I think that personal empowerment, in a sense that you become aware of your ability to make decisions and choices and use that active part of the possibility to choose wisely. I can work with people on that through health. So people can see and discover their own ability to make choices and to look at things and ask questions and be informed and benefit themselves and others through the vehicle in some ways of health. So for me, it's always about a journey with a patient or a client, about them getting to understand something. And I just love it when you see a client's eyes sparkle when they've got something and they've understood and they've made some process themselves. So it's the sort of opposite, I suppose, of paternalistic medicine. I want to see people recognize their own strength and their own power.
So allowing them to empower themselves rather than relying on, I suppose, doctors or anyone really to give them health. Because in some way, would you say that that's kind of the system that we have, is the idea that we go to the doctor and they will fix us rather than the other way around?
Yeah, so it's something I hadn't thought about for many years with the National Health Service, is if you've got, and of course there's individual variation, but if for a country you've got a national health service and people think that they rely on that service to deliver health, to serve them health, then people expect that that is going to keep them healthy, or that that's the main process and the main channel, the main route for maintaining their health. But it's absolutely not. It's people call it the National Sick Service, and that's fair enough. That's what it's really doing, but it's really not about delivering health. And I think that the stronger the system is, the reputation, the presence it has in people's lives, more likely than not, that's going to mean that you're going to transfer some responsibility to that system, to that organization. And then you'll be, shall we say, at the mercy of its ability to deliver things that are going to be meaningful for you. And then you've got to ask the question of, what is that service delivering? What's actually its focus? And a huge amount of its focus is on treating symptoms and on trying to extend the life of people with chronic disease through pharmaceutical management.
Yeah, it's very interesting because one of the pioneers of chiropractic, B.J. Palmer, and I'm sure that other people said this as well, said that it is easier, the preservation of health is easier than the cure of disease. And that has often been an ethos and philosophy of a lot of the chiropractic kind of culture, is that we want to try and get to the cause of an issue. And that's, I think, been a bit of a frustration that it's been quite obvious within our healthcare system. Although they do lots of things really, really great, getting the cause of an issue or preventing an issue is perhaps something that's been a little bit lacking. And that's what when I first heard about you, is something that stood out. And so you work in intensive care, but you also do your own practice, which is where you're trying to get to the cause of people's issues. Do you want to explain more about that?
Yeah, so I once heard intensive care medicine being described as finding someone who's fallen off the edge of a cliff, who's currently holding on to a small branch, and giving them a slightly bigger branch. And, there's not much as far as empowering the patient goes within critical care, other than the fact that being alive does always give you the opportunity, and that, it's not to be sniffed at, right? And intensive care is great because of the challenging situations for myself personally, for the staff and family interactions, but really for that integrated view across organ systems for each individual. You can't sort of separate the heart from the lungs and oxygenation and cell health or different organs. You got to see it all together. But some years ago, I went and did the first sort of functional medicine course, and there the message of look for the root cause was often present. But I felt that really there's another layer behind the root cause question, and that's what's the root cause of the root cause. So why do you choose to go and do things that you probably already sense are not healthy? So a lot of people have an idea about how they could improve their health. Yeah. So they understand the root cause is to do with diet, to do with exercise, to do with social interaction, to do with all these factors. But it's difficult for them to change. And so from that, I would go back and say the root cause is our mental health, our emotional well-being. And that then tied in with my background in Buddhist meditation, with the breathwork training that I've done, with how I try to enjoy and interact with life, with the sort of stress biology I started studying at university, and then with the psychotherapy training I did with Gabor Mate. It's to see that how we pick and choose and relate to ourselves, is very, very key. So if you look at food intake, there are people who I've worked with who are denying themselves food because they think that they're not worthy enough and they should actually just work through every single lunchtime and not take the time to go and eat. Yeah. And then they have health issues related to essentially being in a low fuel state. Then you have other people who, through distress or tension or excitement, and many of us will experience these different things at different times, they will overconsume. So if you don't ask, why do you do this? You don't go to the root cause of the root cause. Okay. And then we have this whole circle of people feeling guilty and bad that they do these things. They say, I feel guilty about overeating. And so then there's a negative feedback cycle associated with that. But actually, they learnt to do these behaviors at a time when it was going to benefit them. So there's what you can call sort of intelligent coping or the wisdom of the body. You've got a book over here, Bessel van der Kolk, The Body Keeps the Score. Yeah. And, our body is much, much smarter and more intelligent than we're aware of. So it's picking the safest route most of the time. People think, for example, that the process of fibrosis and scarring in the body is harmful. Well, it's not good when you've got fibrosis and scarring, but it's a lot better than that organ or tissue falling apart and having a hole in it. Okay, so there's a reason why our body does and produces different results, different mechanisms, different actions, different ideas. In general, it's supporting us. So when we understand that those patterns were intelligent at the time, they just maybe don't suit us now, then we can go back and understand why we developed those patterns, even through, for example, the internal family systems approach, that you thank those parts that brought on those behaviors, and you understand what were they addressing. Yeah, and then you try to see if you as an adult can address those issues. And I think that, for me, to take that whole spectrum between the understanding of why you develop patterns, as well as what patterns you've got, what diseases are manifesting subclinically that you don't recognize, what's now driving the current risk and issues, and to work with people on a journey on that. That's, for me, fascinating. And I hope it's worthwhile. I certainly enjoy doing it.
Yeah, well, I'm sure your patients do as well. As I was mentioning earlier before we started recording, my dad had a heart attack a year and a half ago. And we as a family, we do tend to veer on. We rather not go straight onto medication until it is really, really necessary. We will much rather spend the time and get to the cause of an issue. One of he had quite a frustrating journey because they wanted to put him on a lot of medications, and he wanted to have the conversation as to, but what caused this? Because he's not overweight, he's not a smoker, he basically has none of the traditional risk factors for heart attack, and yet he had a heart attack. And so, and even when they looked at his blood pressure, that was normal, cholesterol was normal, all these things there was nothing that was an issue, and yet he still had that heart attack. So he was kind of doing a similar thing. He wanted to ask the questions why, but his frustration was he didn't get any support along the way, and he even had one doctor say something along the lines of, "If you don't take these medications, you will die," which is just crazy to think that there's surely more than one way that this goes about, and I think that is such a healthy thing to be able to say why. And I like it because usually I've just gone as far as why does this occur, but the why of the cause or the why of the why, then it goes even deeper. And I've often have thought that it's more sometimes it's not a nutritionist that people need or a doctor, it's more of a psychologist that people need, isn't it? or at least that aspect of how do you form habits, how do you change, because change isn't particularly easy, is it?
Yeah. So well, there's a few things to pick up on there. One, there's the psychologist question, and then there's what's driving coronary disease and how are we managing it. So I think we can probably work on those topics for a little while. Yes. So we've gone down a path of separating different roles within society. We can see that very much in medical practice, where we've gone super specialized. But we've also gone to the point where you go and see a psychologist rather than seeing your aunt who lives down the road in the village and has been through things and experienced things before. So we've we've taken out that sort of the beneficial role of the local community or our own community, which is what we would have historically grown up with, and separated things out. And then people find it awkward or difficult to go and talk to a psychologist. Yeah, it's somehow a sign of, oh, I've got a problem, or I don't know, or I don't want to talk to a psychologist about it. But you're where's the bit that's separate, that's supposed to be your mind? Yeah, it's not like, I mean, you can identify the heart connected to everything else, but your mind, your mental state, where does that? What is that? Is that your brain? Is it not? We're so interconnected, and medicine completely misses this. Almost all of medicine misses that. Now, there's benefits from separating, from siloing, because I wouldn't want my if I needed to have a bypass graft for severe coronary disease, I wouldn't want to have an orthopedic surgeon or a rheumatologist doing that. So there's the clear benefit, but that benefit from siloing means that you stop having an overview of somebody's health. Now, you said about your father and coronary disease. There's a really important study that I'd like to talk with you about. It's called the EuroAspire study, and it was in 2015. They looked across 24 countries in Europe for adults between 18 and 80, male and female, and they looked at everybody who had a coronary event. So they had either what's called a PCI, so an interventional angiography procedure on their coronary arteries around their heart. They had had a heart attack, or they had coronary artery bypass grafting. So serious coronary disease people. And they had 8,000 people in the study. And when they looked at how many of those people were diabetic, just over a quarter of those people were diabetic. They were known to be diabetic. Then they looked through the results of the rest of the population, and they found that approximately, because they didn't have all the data for everybody, but from when they could analyze the rest of it, it would mean that roughly another quarter of people had diabetes but didn't know about it. And then another 35-45% of people had the criteria to meet the American Diabetic Association or the World Health Organization's definition for high risk of diabetes, which includes prediabetes and some other indicators that would suggest that you're well on the way to that process, meaning that only about 5 or 6% of that population had demonstrable what they called normal glucose metabolism. Now, if you look at those values, I would say that at least half of those people probably didn't have normal glucose metabolism. So we could see, for example, a marker called HbA1c, which is a marker of how well sugared or glycated your blood, your red blood cells are. They tolerated people up to a level of 39 millimoles per litre. And I would say that normal is probably under about 34 and ideals under 32. So they were taking people who were quite a long way down, as far as I'm concerned, the pathway of metabolic dysfunction and insulin resistance. It would be fascinating to know, if we actually looked at insulin responses to glucose loads, whether everybody who's having a coronary disease has got this problem. And I think it's absolutely massive. It's absolutely central to coronary disease. It's essential to stroke. It's essential to dementia. It's essential to cancer as well.
That's quite interesting, because after him doing quite a lot of research, one of the major things he's done is cut out and reduce his sugar. And traditionally, I don't think that's the first thing people think about when they have heart issues. And funny enough, and I'll be interested to hear what you think of this, he's massively increased his fat and protein, which again, traditionally you would think that's crazy for heart. But it seems to me that the research is starting to turn towards the metabolic side of the issue. And and he's definitely seen improvements despite him not being on any medication. So he's now doing intermittent fasting, and he's doing low carb, very, very little sugar, but massively increasing meat and fat and protein. But what he's also doing, which I think is very important, is he's focusing on the quality of the meat. And what frustrates me is when you hear people say, or when you see in studies where they say that red meat causes cancer. But I mean, maybe you can correct me if I'm wrong, but I haven't seen them distinguish between the quality of the meat. Is the meat coming from the supermarkets and the way that they process it, or is it coming from your local farm shop? What are your thoughts on that?
Okay, so if you see that insulin resistance is the primary driving factor behind coronary disease, and to understand that, I need to make some of the links there. So insulin resistance will drive up blood pressure. It causes thickening in the arterial wall. It will cause a raise in your LDL cholesterol, which is a proxy for the problem. So we see LDL going up, and so that's why people want to treat it, but it's not the cause of the problem. It's a sign of metabolic dysfunction.
So the LDL is actually raised because of the blood sugar issue?
Not blood sugar, but insulin resistance.
Insulin, okay.
Not exactly the same.
Okay, sure.
So the insulin resistance is driving high blood pressure. It's driving increase in triglycerides. It's driving an increase in LDL. It's driving a decrease in HDL. So all the factors that are kind of commonly recognized to drive it, it's driving obesity. So all the factors of metabolic syndrome, although diabetes or poor insulin control is one of them, that insulin resistance is central to all those problems. Okay, so you will see. So insulin resistance it's the process that leads to type 2 diabetes, but you can have insulin resistance without having type 2 diabetes. And the ways that we mark and track insulin resistance on the pathway towards diabetes don't always show you whether you've got insulin resistance. So you can have a normal HbA1c, which is the marker that we're looking at on the pathway towards diabetes, but you can still have insulin resistance. So why do people get insulin resistance? Well, they get it because they have more carbohydrate in their diet than they're using. Okay, so if you have lots of carbohydrate and you're not really active, you're not growing. So it's great if you're burning energy, carbohydrate, simple fuel, fantastic. If you want to grow and you need some fuel to grow, you're a teenager, you're pregnant, you're recovering from illness, that sort of thing, within measure there, because you need to look at other things. But growth states, that's totally fine, I think, to take a certain amount of carbohydrate in. But historically, most people are eating a very high carbohydrate percentage for their diet compared with what we've probably eaten ancestrally. That then drives insulin. So insulin's got to be there every time there's a bit of carbohydrate. When we say carbohydrate, we mean sugars, both simple and joined together sugars, but essentially carbohydrate and sugars are really the same sort of thing as far as your body's concerned, because it always breaks down carbohydrate into sugar. Insulin's got to be there to push glucose out of the bloodstream. That's a very important function for insulin, because if we get too much sugar in our blood, not only can we, if we can't get it into the cells, not only can the cells not use this fuel, but high glucose in the blood cells causes damage. So insulin says, I've got to be there in enough numbers to make sure the glucose comes out of the bloodstream and goes into the cells. However, insulin doesn't just affect glucose. Yeah, insulin is driving everything towards storage. Okay, and it's blocking the process that allows you to take things down from storage. So insulin, for example, blocks the enzyme which allows a triglyceride molecule, which is inside your fat cells, to get split up in the way that it can then travel across the membrane of that cell and be used as fuel. So insulin resistance blocks you from weight loss. Okay, it drives the process of growth in the arterial wall, which gives you the high blood pressure. Okay, so it's very widespread in its actions. And so, yeah, your father's moved away from carbohydrates, from sugars. Yeah, that means his body hasn't got to produce as much insulin. So over time, those stores can come down that he's got for fat. His body can then utilize the higher content of protein and fat that he's eating. And then we come to the question of red meat. So the studies that we have are based on populations which represent an average picture, not you as an individual. Okay. The studies that are showing association, not causation, but those terms get muddled. They are food diaries of people saying how often they ate meat, and they're not distinguishing between processed red meat and unprocessed. Okay. Minced beef will technically be a processed food, but it's not an ultra processed food. But those studies are not distinguishing. Now, if you then ask yourself the question, where's the jump between ultra processed meat, sausage roll, a burger from a hamburger chain, and unprocessed red meat that's come from a standard UK farm, and then you're looking at grass-fed beef that's come from your local farm shop. The enormous difference is between the processed and the unprocessed. We can see that there are some differences between the grass-fed and the non-grass-fed, higher content of omega-3s and things like this that appear to be beneficial. Yeah, but the actual ability, if you take somebody and switch them from processed red meat to unprocessed, you will see a big shift in the health. You shift them from standard unprocessed meat to farm unprocessed meat, you'll be lucky to see much difference. It might benefit long term out, but the markers of significant shifts in health occur on that first step.
And that's particularly important because most people struggle with that first step anyway. So to tell people to go from that first step to grass fed is probably not worth the jump. You probably should make that first step, and then you can look at then the grass fed.
Yeah, I think the benefits for grass fed are great if you've got the money to access it. If you've to support that sort of side of farming, I think it's usually a much more appropriate way to treat animals, and that can be that's a really important factor. But the actual return for health, that's less.
Is there anything? I mean, obviously, I appreciate, because I know in your practice you do. It looks like quite a lot of an extensive testing, at least in some people, and obviously I'm assuming that's because everyone is very different, and for you to be able to really give them the best advice and the best treatment, you need to be able to know everything that you can about them. As a general, or let's say from the limited knowledge that you know about my father's case, would you say that is one of the best strategies for someone that has coronary heart disease? And is there anything else important that we should be adding on top?
So, the first factor I would be thinking about for someone who's got coronary disease is a low carbohydrate or ketogenic diet. So if they've got type 2 diabetes, I'd go straight for a ketogenic diet if they're open to doing that. If they've got some insulin resistance or a pre-diabetic, then I'd see about a low carbohydrate diet. So that would be the first thing I'd probably go for with those people. Then you've got to think about which factors are associated. There's one more sort of negative factor, which will probably get addressed if you do those sorts of dietary approaches, and that's visceral fat. So the fat that's in your abdomen, around your organs, not the stuff that we just notice and can pinch on the outside, but visceral fat, which is inside and around our organs, that's very closely associated with long-term health problems. Subcutaneous fat not got much risk. Seems to be beneficial in some circumstances and not in others, but it's pretty minor. So you've got, for visceral fat, you've got the picture of stress and excess calories. Now, you can handle often the problem of excess calories if you give your body the ability to use the fat stores that are there, which requires you to lower your insulin. Okay, but it's excess calories and cortisol that seems to be the predominant factors driving visceral fat. So if you also need to look at your stress if you want to optimize that. Okay. And stress is a big topic. It comes from lots of different directions. And then you want to think about which factors actually drive health. Yeah. So take away the rotten apples and pick and enjoy the lowest hanging fruit. Yeah? So what's going to drive health? If you've got good muscle mass, you're going to handle the carbohydrates much better. You're going to be able to be active and do many more things. You're much less likely to fall and have an injury. Okay, so high muscle mass is really well associated with good outcomes. Alongside that, you've got what we call your VO2 max, so your maximum oxygen carrying capacity, which is about your cardiopulmonary and cellular, shall we say, mitochondrial health. So the higher your VO2 max, that's one of the best predictors of longevity. And that's actually where I sort of started off on my journey with moving into health, was I did research on VO2 max and exercise capacity as a way to predict poor outcomes for major surgery when I was an anaesthetist. And I then saw that not only could you look at VO2 max and what we call anaerobic threshold, but you could also discover a whole load of other patterns to do with breathing control, to do with obesity, to do with mitochondrial health. And that's when I started a fatigue clinic looking at people with different forms of exercise intolerance.
And I heard you talk about muscle as a metabolic organ. Yeah, I thought that was quite interesting. I've not heard it termed like that, but that very much makes sense. Can you explain a bit more?
It's the biggest metabolic organ in the body. That's where most of your mitochondria are. So most of your energy is being used. And it's a great regulator. So it's actually works as a reservoir. So if you take in a lot of protein, which is broken down into what we call amino acids, sort of building blocks of proteins, then those can get stored in your muscle. And then when you need to build proteins in your body, you've got a nice reservoir there. And people, I find it surprising how should we put it? How we don't understand just how central protein is, the proteins in our body, to function. Yeah. Now, most people would recognize that your DNA is really important, right? But what's your DNA doing? Your DNA is a blueprint for proteins. It's either a plan for a protein or it's a plan for a molecule that helps you build proteins. Your DNA is all about proteins. Yeah? Proteins are the clever bits in your body. They're the ones doing the funky control on the cell membrane, moving your body, all kinds of things. It's proteins that are the super smart molecules in your body. If you look at a typical cell, maybe 70% of it is water. Take that water out. Protein's the predominant thing that's left. Yeah. Then you've got some fat and you've got a tiny bit of carbohydrate in each cell. Yeah? So when you want to build a cell, when you want to build something in your body that's going to be clever and help you to work well, to optimize you, you need proteins. Yeah? And a lot of people are not getting enough protein. They're certainly not getting what we consider an optimal level. Most people don't understand much about the quantities for protein. So that's the protein side for muscle. But then there's the glucose side. Now, if you were to look at a young, not necessarily young, but a bodybuilder who's got a large muscle mass, they can take in 300 or 400 grams of carbohydrate in a single sitting, and their blood glucose won't spike. Yeah, and that's because they send the glucose straight to the muscle. The muscle can use it, can store it, and can release it whenever it's needed. So muscle's a great protector.
And that's the nuance then, isn't it? It's not necessarily that eating a lot of carbs is bad for everybody. One example of what you're saying there is depends on how much muscle mass you have and how well your body can actually deal with it and how much you're using, right?
Yeah, and how much you're using.
Yeah.
But Yeah, so I think we've got it in general the wrong way around as far as the way we're consuming the macronutrients. I think carbohydrates, in general, I say to people, think about when you need carbs, yeah, and how much to have for them. Yeah, the key is to get enough protein and enough fats. So we talk about things that are essential in nutrition. Okay, essential means you can't make them in your own body. Yeah? You've got to consume them. So there are essential amino acids, there are essential fatty acids. There's no essential carbohydrate. Okay, so it's optional. And people think, yeah, but I need glucose for my cells. I need glucose for my brain. It's the only fuel my brain can use. Well, it's not the only fuel your brain can use, and you don't need to consume glucose to have glucose in your blood. Your body can produce glucose without having any carbohydrates at all. So it can make all the glucose it needs, and it can produce other fuels like ketones, also lactate, and some other molecules can be used by the brain.
Yeah, and that's demonstrated in the fact that you can survive without any sugar. It doesn't really have any nutrients in it anyway, does it?
Yeah.
But the ironic thing is for so many decades, the food triangle has had carbohydrates as the highest proportion.
Yeah.
which now is like, oh, actually, maybe this doesn't make sense. Does that therefore, do you have any concern then for this push for reducing meat and for the vegan push? Because although it's not to say that on a vegan diet you can't still have high fat protein, but my perception is if you're going to do a vegan diet, you've got to do it really well. Whereas if you're not very good at cooking or you don't know a lot about food and you're eating meat, you're probably quite safe because meat has everything that you need in it. Is that a concern for you?
I think a vegan diet is an advanced nutritionist's diet. I've only seen, so in this fatigue clinic that I ran for 5-6 years from sort of 2015, I asked almost every patient about how much protein they had because I saw very quickly that they had problems with their nutrition, with their sleep, with exercise, with stress, with lots of different factors. I had one patient who met what I thought were appropriate guidelines for their protein intake, and that woman was a nutritional therapist.
What were they eating to get that? Just a lot of beans or something?
Yeah, you've got to eat. Well, the first thing to understand is when you look at plant-based proteins, they tend to be a mixture of carbohydrate and protein, whereas animal-based proteins tend to be fat and protein. Okay. Now, when you average out the calories that you get with these plant-based proteins versus the animal-based proteins, for every, let's say, 100 grams of protein that you get from a plant-based protein source, you'll need 2 to 3 times the number of calories compared with if you take it from an animal-based source. Okay? And that's because of a variety of factors. One, because the protein comes in a lower density, packed with all the carbohydrates, so you get the calories there. The protein is also less digestible, less appropriate in the constituent factors that it's got for your body to use. Okay? So if you want to optimize your protein intake for your size, you need a really large amount of your nutrition coming from protein. You need to basically focus on almost only eating proteins if you want to be kind of safe and sure with things. Yeah. So then you'd be eating, lentils and quinoa and what other sort of plant-based proteins you can come across. The thing that really opened my eyes was asking people if they're vegetarian or vegan or ate everything in this fatigue clinic. About 80 or 90% of the patients I saw were vegetarian or vegan. And that is wholly unrepresentative. It's the complete reverse of what it is in the population. About 10 or 15% of the population is vegetarian or vegan. That told me that either vegetarians or vegans complain more, and I'm sure that's not the case. Their symptoms were there. And I'm sure the association was with the diet. And that's actually the reverse of what you'd expect, because there's something called the healthy user bias. And that means that people who tend to go and become vegetarian or vegan are trying to be healthy. So they're trying to, be healthy on multiple levels at the same time. So they might not smoke or cut down the smoking, drink less alcohol, exercise more, and try and eat well. Yeah. So if those people as a population are trying to do all those good, healthy things, you'd expect them to be much less often present than the people who are going to, McDonald's the whole time. But they weren't.
That's very interesting, because when I made that comment, I had no idea that you had those kind of statistics in your clinic, and the association seems relatively clear. So that's very fascinating. And so, I feel that more recently it's becoming more known and more people are understanding that fat and protein is a good thing, but there are also lots of people that don't. Every time I used to in my practice ask people, do you think you have a good diet? And you always get, yeah, it's not bad, yeah, it's pretty good. And I wouldn't really go much deeper into that, just because that's not the thing we were concentrating on. Recently, what I've started doing is saying, right, what do you actually eat? They'll begin and say, yeah, it's not bad. Yeah. I start with cornflakes in the morning, and then I have a ham sandwich and white bread. And right, okay. People's perception of what they think is good isn't actually that great. Maybe I was more optimistic than I should have been.
The phrase a balanced diet is much abused. If it represents what's on the traditional food pyramids, it's terrible. If it represents what's on food nutrition scores like the Food Compass, it's also going to be terrible. So what people's understanding of a balanced diet is, even if it reflects nutritional guidelines that are out there, is very often very poor.
So the question then begs, with that food pyramid, which has been around for decades, did they just get it wrong? Or is there some kind of malicious intent behind it? Or maybe not malicious, but maybe more monetary?
Yeah. How is it? If you can't understand something, ask. I'm blanking now. Where's the money?
Oh, yeah.
Follow the money.
Follow the money.
Follow the money.
Yeah.
Sorry. So I think what happened was, post Second World War in the US, they'd been funding farmers to produce food, carbohydrate in particular, the different grains, sugar, corn, wheat, were heavily subsidized in order to produce enough food. That funding, no one wants to lose funding when they've got funding. So there's a big lobby to maintain that. At a time when they saw fat in the arteries of people who'd had coronary disease, they thought, even though there was quite a bit of evidence actually that sugar was harmful at the time, they thought, well, we can see fat there, we're going to go for that. Decisions were not made based on evidence. And then you have to understand there was a powerful lobby behind it. As we've eaten less and less meat in the last 40, 50 years, chronic disease has gone up. Okay. Now, that doesn't mean that meat consumption will prevent chronic disease, but what it tells you is that chronic disease consumption is not due to red meat consumption.
Yeah, I mean, it's the same idea. If you saw a dead animal on the road and you saw some maggots on it, you wouldn't jump to the conclusion that the maggots killed the animal. So just because you see it there doesn't mean that's
Correct.
a cause.
Doctors are highly associated with death.
Yeah.
When people die, there's very often the doctor in close proximity. Yeah. So, remember that. I remember some surgeons being very worried about certain drugs we would use on patients, because they noticed that as the levels of those drugs went up, patients were more likely to die. And that was true. It's because those patients were sicker.
So they needed more.
They needed more. So, you've got to ask the question, why is fat there in atherosclerotic plaques? Is it causing the problem, or is it trying to fix the problem?
And if it seems like then the traditional medicine hasn't caught up with that, because when they see someone with high blood pressure, they give them medication to treat the high blood pressure, but they're not asking, why is the blood pressure high in the first place? When they see fat in the arteries, they're treating the fat rather than saying, why is the fat there in the first place?
So we are treating proxies most of the time. Yeah, we're not treating the actual cause of the problems. There's different evidence for different treatments of proxies and the process. So I think the outcomes from having your high blood pressure managed, although it's better to actually get to the cause of it, taking the medication for it is going to extend your life. Yeah. Whereas taking the cholesterol lowering medications like statins, if you look at the data where they've actually asked the question, how much extension of life happens through the use of statins in primary prevention or secondary prevention. Primary prevention is stopping you from getting an event in the first place. Secondary prevention is how do you treating somebody who's already had an event. We're talking about 3 or 4 days from the study that was produced in the BMJ a couple of years ago. Yeah, so that's a very small increase in mortality. Yeah, or a very small change in life extension. Okay, which is what people actually care about, and that data is data from drug companies, which we know are biased. So if a study is funded by a drug company, it's 5 times more likely to show a result in favor of the drug than not in favor of the drug. And then studies like the Jupiter study, which makes up a lot of the evidence for the use of primary use of statins, they do what's called a pre-trial. So they give everybody a statin and then say, did you have any side effects? If you had a side effect, then you don't go on to the actual main study. So it's a nice way of clearing out the people who've got a problem from a drug. And then all the data you gather is on the people who were not intolerant of the drug, not initially at least. And then the results of that study is what informs your GP. So the risk profile, I don't think we have a good picture on it, and we have a biased view on the benefits.
So let's go then to exercise. So we were talking about metabolic health, and just using a bit of logic here then, if we're saying that protein is really important for the reasons that you said, and muscle is a metabolic organ, is there a difference between the types of exercises that we should be doing, particularly looking at cardio versus strength-wise?
Yes, we should be understanding both aspects. I think you certainly can gain the cardiovascular benefits of endurance exercise by doing resistance exercise. If you do resistance exercise in a certain way, you cannot get the muscle building aspects of resistance exercise from pure endurance cardiovascular training. And within cardiovascular training, we should be thinking about the zone 2 or lower training, which is actually stimulating the mitochondrial health of muscle fibers so that you can burn fat more efficiently, and the higher peak aspect of training. And what people tend to do is they merge those two and they end up with a higher stress than they would get benefit from, and they miss actual benefits they would get there. So you want to be separating out in some ways your endurance training.
And can you explain what zone 2 is?
So there are lots of different ways of classifying zone within exercise training. Okay, most of them are not individualized. They're based on your age and therefore predictions of your heart rate, and then working at percentages of your heart rate. Okay, so that might be reasonably appropriate for a large population, but it's not a good guide for you as an individual, because those zones might be, completely discordant with what your physiological ones would be. So if you test people and you do a VO2 max test, you can see their whether they are burning different fuels at different stages, and you can see at which point they transition. Okay, so you want to be up at the top end of your aerobic metabolism, where you're burning fat and stimulating those mitochondria and saying, look, we need you to be here. Yeah. The body's responding to demands, to inputs. Yeah. So the more you demand, the more you study, the better you'll get at understanding and learning and reading. Yeah. The more you try and do a sport, the better you'll get at that. Yeah. So the body's responding to the demands we put into it. We ask it to have, or we demand of it. So when you say to those muscle fibers, we need a lot of this working well, they will release the factors that drive more mitochondria to be formed, and those mitochondria to be healthier and more efficient. Okay, that will increase your capacity to do activity within, let's say, the comfort zone of health, of exercise. By that I mean you should be able to exercise in your zone 2 and not feel tired the next day. Okay, that's usually a good indicator of whether you've done zone 2 exercise. Another indicator is that you can just about hold a conversation while you're doing it. You take a little breath between sentences, but you can complete the whole sentences. Okay, that's part of what we call the talk test way of doing of assessing it. Yeah, but ideally you want to measure it and see exactly which heart rate zone you've got. Now your heart rate zone will even change according to whether you're more tired or whether you've had caffeine or you're dehydrated or other things like that. So that you need to, if you want to get it really right, you need to sort of learn about how to perceive the level of exertion and not just be dependent on heart rate. But that's one way to get into zone 2. Okay, and then there are ways of working with the higher levels of the zones so that you stimulate other energy systems within the muscle fibers. Now, if you do a zone 3 training, you'll miss out on some of the benefit that you need for the zone 2 training, because you just won't have that same metabolism going on, because your body's going to say, we can't manage with that, we've got to go carbohydrate based. Yeah, and you'll burn more carbs as you go into zone 3. You're also going to be more tired. You're also going to be more likely to cause injury. Okay, so we need to understand the physiology of our body if we want to stimulate it in the right way.
So are you saying that zone 2 would be better than zone 3 in that instance? Yeah. Interesting. So because there is the idea that if you stress your body too much, that is, I mean, I think we see this actually. If you stress your body, in fact, I saw this last year. I started going in the ice bath, and ice baths are meant to be great for boosting. One of them is boosting your immune system. Funny enough, I got more ill in that winter than any other winter I've ever done. So it's outside, and I was going in about 3 to 4 times a week, and about 5 minutes each time. Now, I'm not the biggest guy, so I do get cold really easily. The fact that I even started it was amazing, because before that I couldn't even get in cold water without not being able to breathe. But then I got used to it, and I actually really enjoyed the benefits afterwards. What I think I realized, I think there may have been some other variables here, but I think one of the biggest variables was that I was actually stressing my body too much and putting too much of a load on my body that then made it easy for me to then get ill.
We need to look at stress as a big package altogether. We can think about a stress load. Yeah. So if, for example, you're working a very, very busy and intense job, potentially with lots of travel, lots of meetings, yeah, that's a large stressor in itself. If you then spend the weekend exercising like crazy because you're doing an Ironman in a few months' time, you're at a very, very high stress load. Yeah. You're much more likely to have injuries. You're much more likely to get exhausted. You're much more likely to develop chronic fatigue. You're much more likely to have a dip when you stop afterwards. Okay. If you take on a lot of stress in life, yeah, you need a lot of recovery. Okay. So you can match your stress with recovery. And that means genuinely taking time off. Yeah. And making sure that you prioritize sleep. So if you work hard during the week, train a lot in the evenings and the weekends, drink some alcohol before you go to bed, disrupt your sleep, get up early to go to work the next day, your stress load is really high, even if you're the most chill man or woman on the planet. Okay? So the load is large. So you have to look at your total load. Then you've got to look at your perception of that load. So you can shift your perception of the load by, if you're the more relaxed type, if you've meditated, or if you do other things that allow you to look at the situation and say, oh, this is happening now. It might seem very, very important now, but in 10 minutes time, it might seem half as important. And by the end of tomorrow, I've even forgotten I was in the stressful episode. Yeah? So that can change your stress perception. Then you've got your, should we say, stress capacity or stress reservoir. That's how healthy you are. Yeah. So do you have a physical body that can take on a stressor? Because you're fitter, you're stronger, you're not carrying disease, you can deliver oxygen well to your body. Yeah? And then within sort of stress perception, there's also, do you have any particular individual triggers? So do certain situations affect you more than they would affect somebody else? Yeah. So does sitting in a hostile board meeting remind you, as it did of one of my clients, of negotiating with tribal leaders when he was leading an army, a military, in a military service. Yeah. So it can be amazing what things actually trigger an individual.
Interesting. And so it is really the overall load that you put your body on and making sure, because assuming that's the whole reason behind why zone 2 is a bit easier or better if you're wanting to grow or strengthen yourself rather than zone 3, is because you're not overloading yourself, which then can have the opposite effect.
Yeah, you're going to then lose a bit of the benefit because you'll be working the wrong muscle fiber types than what you probably need to, but it's more tiring.
So then, for going back to coronary artery disease, what would then be the best type of exercise? Would it be kind of a fast walk?
You need to understand how critical the coronary disease is. Okay, so if you get chest pain walking up a gentle hill on the way home, no, going to the gym and doing zone 2 exercise is not the right exercise for you. Okay, if you're in that sort of state, you're probably better off having a sauna, because the sauna will stimulate your cardiovascular system to work more, to increase your cardiac output, and you get a lot of the benefits of endurance exercise from a sauna. Okay, but it also causes dilation of the blood vessels, which is beneficial if you've got a narrowing in your coronary arteries. And then so you need to understand what level of disease you've got. If you haven't got some coronary disease like causing you a problem, yeah, then some zone 2 with a small amount, maybe 20% of the week at peak, will probably do you pretty well.
Okay, so and I'd like to get then onto more of the subject of longevity. We've obviously spoken about a lot of things in that already. What would you say is the most important thing then we haven't spoken about yet in regards to optimizing the longevity of your health and the quality of your health?
So we haven't said that much about resistance exercise. And people say resistance exercise, but what they don't do is they don't see that it's kind of a 3-pillar thing. And one is that you consume enough protein such that your body is ready to build muscle when you damage it through resistance exercise. So resistance exercise is actually causing muscle damage, and that muscle damage is a signal to say we need more muscle to be able to cope with this. So you build back bigger, better. Yeah. So you need enough protein, you need the right kind of stimulus, okay? And the right kind of stimulus is stimulus that's going to make your muscles feel tired or sore afterwards, okay? You'll get some benefit from doing lots of repetitions at a light load, but you'll get more benefit the higher up you go towards your, what we call 1 rep max, okay? Just doing a single maximum repetition is not going to give you the right stimulus, but you only need about 60 to 90 seconds of really high stimulus resistance work, ideally where you're kind of just on the border of coming to failure, okay? And that will make all the muscle fiber types be stimulated and causes lots of growth. Okay. You then need the appropriate amount of recovery time. That's the 3rd pillar. So protein, the right stimulus, and recovery time. Okay. So if you're really stimulating the muscles well, then it's going to take you quite a few days to fully recover. Okay. If you take plenty of days between your resistance exercise training sessions, you will continue to increment for longer. You won't get gains quite so quickly at the beginning, but what you're doing is allowing your body the full opportunity to recover in between. If you found that you're plateauing in your gains from resistance exercise, take a week or two off and then go back. Most people will find they're able to lift more after a week or two off than they were before. And that's because they've actually given themselves full recovery.
And so then how important then is resistance training for coronary heart disease?
Well, resistance training, it wouldn't be the first thing. Yeah, the first thing would be the carbohydrate content, without a shadow of a doubt. But resistance training improves coronary perfusion. You're putting a demand on the heart, so as long as you're not over stressing the heart at the time and causing muscle injury, then it's going to be beneficial. Let me think. So the resistance exercise is going to train the muscle mass, and the muscle mass will have another direct effect on insulin resistance, which will then go back to the pathway of insulin resistance, driving the problems of coronary disease.
Yeah, because if muscle is a metabolic organ and metabolism is really important for coronary heart disease, then that would be obviously an important factor. And that's one of the things that seems to be, I hear quite consistently, is your muscle mass as you're aging is one of the most important factors as you get older.
Yeah, really, really, really central.
Yeah, for really the reasons you've spoken about already, right?
Yeah.
Yeah, okay. What would you say is the next important thing then in regards to longevity?
So what we haven't spoken that much about, which I think tops muscle mass, is your mental health. Yeah. Because who wants to live to be 100 and be, fit and strong if they're miserable? So, when we talk about longevity, what most people, what I care about is a good quality of life, absolutely emotional as well as physical, for as long as I can have it. And then ideally a fairly short period of decline. Yeah. Everyone's happy when they hear about someone who, had a great healthy life and then suddenly died in their sleep, or the patient who was, out at a birthday for their 80th birthday in a restaurant and had a heart attack and died there. It's maybe dramatic and sudden, but a lot of people will identify with the idea of having a long, good quality of life. And then how long afterwards, it's not advantageous to live 15, 20 years for most people. It's not a black or white situation, but the goal is about the increase in healthy life. And what we know is that the longer you offset chronic disease, that means the later in life it starts, the longer you'll live. So if you look at these blue zone populations, you look at people who live to be 100, that sort of thing, most of them don't develop chronic disease in their 40s and 50s and 60s. They develop chronic disease in their 60s, 70s or 80s.
In the blue zones?
Well, not just blue zones, but in general, people who live long. Yeah. So offset chronic disease. You offset chronic disease through metabolic health. Okay. You don't have metabolic dysfunction. You don't have the basis. So if you don't have, hypertension, cholesterol problems, obesity, then you almost never go on to develop coronary disease, or very rarely develop coronary disease, very rarely develop dementia, very rarely develop cancer. So it's foundational. And if you can avoid that, now some of those things you probably can't avoid because there's certain processes where you have a cumulative process. So we often ask the question, what's aging? Or how much of disease is related to aging? And an awful lot of it is really related to the accumulation of insults rather than something biologically happening and getting worse when you get older. People think about this in terms of muscle. So we talk about the decline in muscle mass that happens year on year, particularly from I think sort of 35, 40 onwards. It gets faster. When you're postmenopausal, if you're a woman, it's really increased from 70 onwards. Okay, but if you go to the gym, or if you eat enough protein, do resistance exercise, and give yourself time for recovery, you can increase muscle mass at 40, at 50, at 60, at 70, at 80, at 90. Okay, so it's not that aging is causing that to happen as an absolute thing. It's something you can counter. Yeah, a 60-year-old is less likely to start in the gym than a 40-year-old. So of course you're going to see muscle mass going down. Yeah? Now you can't obtain the same muscle mass and the same strength at 70 as you could have at 25 or 30. Yeah, but you can certainly develop enough muscle mass to prevent you from having most of the problems associated with low muscle mass.
Mm. One of the most common things that really frustrates me, what I hear patients say is, I've got this, I don't know, knee arthritis, it's just down to age. Mm-hmm. And I always think that doesn't make sense. It's more the fact that as the older you get, the more chance you have of that accumulative load and the cumulative trauma. But if it was down to age, then everyone your age should be having the same thing, right?
Yeah.
And it should be in really quite similar in most of the weight-bearing joints, which it isn't always the case.
Yeah, and pretty much everybody should have it who's at your age, right?
Yes, exactly. Yeah, so it's a really unhelpful type of thinking, because it means that they don't think there's anything they can do about it, and so they don't do anything about it.
So I see it on brain scans very often. So CT brain scans, there'll be a shriveled brain. I mean, not completely shriveled up, but certainly smaller than you'd hope it to be. And you get the report, normal age-related change. And it's not everybody who has it.
But it's easier to put it down to normal age-related changes, because that means it's normal, we can move on, and there's less to do.
You've got to think about it, right?
Yeah, you'd have to think about it, yeah. And
or explain it.
Yes, and even as a patient, I suppose you don't have to take responsibility for it. It's although deep down, well, I mean, on the surface even, you don't want to be in pain, or you don't want a shriveled up brain for all the consequences that gives. But at the same time, sometimes to change that and actually get to the real cause, sometimes, well, a lot of the time, actually that requires a lot of energy, a lot of responsibility, a lot of hard work. And that's not so easy. So sometimes actually just to admit defeat and move on is a little bit easier.
Yeah, so if you're going to talk to somebody who's going to feel guilty about you telling them that their lifestyle has been responsible for the disease and the changes they've got, it's a difficult question to think about whether it's beneficial to tell that person. On the other hand, if someone's an adult, and shouldn't they receive the truth? Shouldn't they hear what's going on? Do we want to be told sweet stories and benign things in life? Would you be happy if someone else kept a secret from you because they didn't think you would do much about it? Or you might, would we therefore not tell anybody who was behaving inappropriately in a family situation because we didn't want to make them feel guilty? We take away, as medics, the right of other adults, competent adults, to make decisions themselves about what they want to do with that information. Now, a lot of the time, people are just medics are used to just passing on the same information they've heard before without actually understanding what the situation is. You take, for example, the myths around high protein diets and kidney disease. Yeah, most medics, really, really high percentage of them, will say that you shouldn't have a high protein diet. They'll say it can cause kidney disease, or they will say in kidney disease you shouldn't have a high protein diet. Now, historically, what's the reason for that? Well, when you've got kidney disease, one of the ways that you can detect it is you've got protein in your urine. Okay, that's because your kidney is no longer holding onto the protein; it's damaged, and the sieve that's supposed to hold the protein back has got too many holes in it, and the protein goes into your urine and you lose it. Okay. Now, if you had a condition that meant you were losing protein, yeah, would you want to be on a low protein diet?
No, you want to increase it.
You want to increase it. You want to be on a high protein diet. So that association with high protein, and people thought that it might exacerbate the problem. Yeah, it's the protein content in your body is not driving the kidney disease. Yeah, you've got a process that's driving kidney disease, and as a consequence, you're losing protein. Okay, so people have looked now for those original articles or the case reports. There are none. It's just people. It's just doctors repeating what was there before in previous medical textbooks, regurgitating what was said before, regurgitating what was said before. There's no evidence for it.
And this is quite similar though in a lot. I mean, that's just one example. The other one is the ones we were talking about, like with high blood pressure or with eating high fat diets. For a long time, and still a lot of doctors are saying that that's a bad thing. But actually, like for example, with high fat, but actually that can be a good thing because that can help your metabolic health. That can increase your nutrition. There's a lot more nutrition than having a lot of carbs, for example. So it's the idea of just looking at something and then immediately just jumping to the cause, isn't it? Rather than asking the deeper question, why is that there? Why is that happening?
Yeah, and actually asking, if we manipulate those things, what's the outcome? Sure. So when we give people lower fat diets, they don't have less heart disease. Yeah, there was a Minnesota coronary study done which looked at saturated fats versus polyunsaturated fats, and they showed better outcomes for people with a higher saturated fat. And that the results of that study were not published for I think 19 or 20 years after the study came out because the authors didn't like the results. That's how the story goes, at least.
Oh, interesting. Yeah. So so on that note, then, should we be worried about saturated fats because that's the other demonized macronutrient for a long time, isn't it?
Very much so. So saturated fats are in themselves a big topic. There's lots of different saturated fats, and we think that the outcomes associated with different saturated fats is probably different. There's a sort of general feeling that the odd chain saturated fats are associated with health benefits, whereas the even chain, so the number of carbon molecules in it, if it's an even number, those might be then associated with worse outcomes. Saturated fats are present in all kinds of foods. So we're told, you're told, eat oily fish, they're healthy. Yeah. Don't eat steak. It's got animal fat, it's got saturated fat. Yeah. But actually the oily fish will have more saturated fat in it than the steak will. Yeah. So, fats are mixed together in nature. They're not just saturated, monounsaturated, polyunsaturated fats. If you avoid saturated fats, you will almost certainly be avoiding a lot of good nutrients. Personally, I consume a lot of saturated fats.
Yeah. Okay.
And I'm quite comfortable with doing that.
Well, that says a lot. Yes. I mean, do you think there is a limit though, and does it need to be in proportion to the unsaturated fats?
I can't see any evidence to say it should be. The times when I think people become concerned is when it raises your LDL cholesterol. So about 20 or 30% of people who go on to a high fat diet will find that their LDL cholesterol gets raised when they're on a high fat diet. Now, LDL cholesterol is a proxy marker for cardiovascular disease or for coronary artery disease. But that's when it's driven up through metabolic ill health rather than because you're really healthy, you're on a low carbohydrate diet and you're consuming lots of saturated fat. The first question there would be to ask, is your ApoB count higher, which is the particle count for the amount of LDL cholesterol you've got? And then to ask whether you've got more small, dense LDL, and then to look whether you've actually got coronary disease and it's developing. And the limited amount of information we've got, there's no shift in coronary disease in people who are on high-fat diets and ketogenic diets. But we really don't have the evidence to say absolutely this or absolutely that. At the moment, people, I think, should look at like a sort of best prediction model where if you start a certain diet, and your health gets better and gets better and gets better and gets better, that diet is probably working for you. The challenge is that sometimes when you switch your diet, you have enough stores of some things already and you're then not replenishing those stores initially, but you'll get a boost because you cut out eating a load of rubbish. So you could go to, let's say, any form of restrictive diet where you no longer eat processed foods. Yeah, you just eat vegetables, you just eat meat. Yeah, both of those will come with a health advantage. Then the question is, are you replacing all the nutrients that you need? Remembering that the recommended daily intake values, the RDI values, are not based on those variations of dietary approach. They're based on whole population studies, or they're based on the amount of food that was needed to give to soldiers, young men in the Second World War, so that they didn't come home with nutritional deficiencies. Yeah, that's not you as an individual.
So there's a lot more questions to be asked when you see something like LDLs being raised. So a topic I'm really interested to hear your thoughts on, particularly 3 years on, is the vaccine topic. Now, one of the reasons why I first heard about you was when I saw you on TV, and that must have been a very interesting time for you. I'd like to hear more about that. Well, firstly, can you just explain from your perspective what happened during that time, and maybe your reflections now?
Okay, so I was asked to start working as a consultant in critical care. I was a cardiac anaesthetist before then, but had experience with patients from intensive care. And when I started looking after patients during the pandemic, I noticed the prevalence of metabolic disease for people. So almost everybody was obese or had type 2 diabetes, or at least had one other significant metabolic disease. One thing that I noticed was I saw a lot of patients with diverticulitis, and I was like, why is that? And then I later on that diverticulitis is closely related to visceral fat. It's driven by insulin resistance. It's closely related. So there were lots of things that were all pointing pretty quickly to metabolic disease as a foundation for what COVID could then cause, the symptoms that it caused for people. I recognized that I was almost certainly going to get COVID at some point. Yeah. And I thought, as a young, healthy, I could still consider myself young, you see, young, healthy person, I was going to get this virus and I'd be fine. Yeah, maybe I'd be tired for a week or something like this, but I knew how to look after my health. I wouldn't try to push myself back too quickly. I'd recover from this virus, yeah. So I started to understand it in those terms. Then when we was talk about the vaccine coming out, I thought, okay, well, that might be useful for some people, yeah. But I also knew that the natural history of viruses is that they become less pathogenic, so they're much less likely to kill you a year or two down the line or give you worse symptoms, because the virus essentially doesn't want to kill the host. It wants that you survive and spread it. So it likes to sort of find the sweet spot. So as viruses naturally mutate, yeah, then the virus that is able to spread the furthest becomes the predominant one. And that's why we had those changes in the variants. Yeah. So then there was the situation when the vaccine was on offer, yeah, and I was a little bit surprised initially when some of my colleagues were quick to go and have the vaccine, but people are individuals; they can choose these things. Then I saw that the vaccine was being offered to more and more people, and it was being offered to adults who were my age and younger, and actually asking, at the time and shortly afterwards, it was a very common question. Have you had a vaccine? Why did you have the vaccine? Yeah, I know very, very few people who wanted to have the vaccine. Some who were medics who were concerned, especially in the early stages, potentially had some metabolic health issues themselves, might have felt themselves to be more at risk. Yeah, I can understand that. But the vast majority of people had it because they wanted to go on holiday, they wanted to visit relatives, or they were asked to do in some kind of work situation, or there was family pressure. Yeah, and that's hugely significant. that most adults that I know didn't take it because they wanted the vaccine. They were forced to. They were essentially restricted, they were bribed, they were manipulated by the system to take it for that. Did it stop them getting COVID? No, it didn't. Did it stop transmission? No, it didn't. Yeah. And so when I was being told that there was now this vaccine mandate in the NHS and that all staff had to be vaccinated by a certain date or they're going to be fired, I thought to myself, what am I going to do? Yeah. What am I going to do here? I wasn't that worried about taking the vaccine. I didn't think it was, going to kill me a week later. Yeah. Although I had started to hear about people having quite severe side effects from the vaccine. But on principle, I felt this was really wrong, that people should have to take a vaccine where the evidence was really equivocal as to whether there was any benefit at all. I looked at some of the studies, and the studies showed that most transmission within hospitals occurs between patients who are sick rather than staff. The easiest way to stop staff passing the virus on is that when they're symptomatic, they don't come into work. That's quite a good method for stopping viruses being transmitted. There's no significant evidence historically for asymptomatic transmission, so you haven't got to worry about people who haven't got any symptoms passing the virus on. No pandemic is driven by that. It might happen sometimes, but it's not the driving force. There was some associated decrease in transmission for a few weeks after people had been vaccinated, but you're not going to vaccinate someone and then vaccinate them again and then vaccinate them again and then vaccinate them again, right? And then there was the fact that I had COVID. I had antibodies, yeah. So there were so many factors, and I thought about it over Christmas and New Year and said to myself, I'm not going to have the vaccine. I was offered a couple of opportunities to have a false vaccine passport. That was certainly happening. I know quite a few people who did that. They weren't in a position that I was, where I could say to myself, if I lose my job in the NHS, I could make a living doing health for people because I've got this wider knowledge base. Yeah. And I thought, if it comes to it that I'm forced out of the NHS in this way, so be it. I'll go another route. And so I was fortunate enough to have support from my wife, my family, my friends. Well, maybe cut that bit. Support from my wife and my friends. I think my family were more worried than I was about that.
Okay.
And so I said, look, I would just love to have the chance to challenge people on this. And I spoke to the CEO or the deputy CEO from King's College Hospital. I spoke to my head of department about it. They were not in favour of a mandate, but they weren't in the position to be able to challenge that and to say that we should take this on and change things. And then one morning I was told that Sajid Javid, the health minister, was coming to visit my intensive care ward, and I had the opportunity to talk to him about it and express some of my feelings.
Did you have any idea that it will go, because it went relatively viral, didn't it?
Yeah, it did.
Yeah. What I remember about it. So, firstly, I was really impressed. It was very admirable for you to do that, and it was very because I was on the similar kind of lines as you. When I heard about the vaccine, me as well as my family were on the bias of, we rather, as I said earlier, we'd rather not take something if we can get to the cause of it and just be healthy. And I thought it didn't make a lot of sense, but I thought, let's try to be as unbiased as I can be. Let's look at the research. And I was very surprised when the research came out to say 90% effective at reducing transmission, 95% effective at reducing transmission. And I want to ask you about that in just a sec. When I watched the clip of you, and I saw it in the comments, I just rewatched it a few days ago. Someone said the silence of the nurses was just as impactful as the words that came out of your mouth, because there was this kind of silence after he asked, "I said, what do you think about the vaccine?" And they kind of looked around, and then suddenly you kind of spoke up. I think the most frustrating thing about that was that you gave a very logical argument and there wasn't a logical argument that came back to you. The response was, well, that's your view. What was the other thing that he said?
We take advice from the experts.
That's the one. Yeah. And I was thinking, well, surely you are the expert. You are the head. I mean, even if you're not medical, surely people are telling you what you should be saying. You should be able to come back with a logical argument. And there was just nothing.
Ministers said that they were taking advice from news stories on the BBC. So that's the level of rigor with which some decisions were being made. And you can ask questions about the BBC's quality of journalism. I know many people do. But that they were getting that as their source and making policy changes based on news stories tells you how wrong they were. They, when you're siloed and down looking at a certain thing, you're used to hearing what you're used to hearing. You're used to believing certain stories within medicine, and people don't pull themselves out and ask and say, why have we made these changes in policy that we did with COVID? So why are we using PCR to test people who are asymptomatic? If you test people who are asymptomatic with PCR, you have a completely different set of data compared with if you test them when they're positive. Yeah, the positive predictive value and negative predictive value are different, whether you're symptomatic or you're not symptomatic. We've never before had the advice that you should stop travel. Yeah? We've never before said isolate the healthy. And there were crazy decisions made during this time. The 95% reduction, that wasn't in transmission, that was in symptoms, people who were symptomatic. So who were then tested positive. And 95% reduction is about a relative change. So you're talking about if 2% of people had it, you're going down to a much smaller percentage, 0.02 or something like this, 0.01. Yeah, you're not talking about 100 people going down to 5. Yeah, and then what we're not asking the question about was, are you just stopping people getting it this week, but they all get it next week? And that's what happened with COVID. You stop people getting it for a week or two, but they got it afterwards. But they also got the vaccine. And we really don't know, but there's a lot of concern about whether the vaccine has driven lots of autoimmune problems, what people are calling turbo cancers, what people are having sort of neurological deficits from, as well as some of the immediate problems that we saw early on with cerebral vein thrombosis. I think a really, really big crime was not to track the outcomes, not to have any kind of proactive monitoring, to say it's the largest medical experiment that's ever happened in the history of this planet, and to not take large enough groups of people and be able to compare them either in a randomized controlled way where you say some people don't take the vaccine, some people do take the vaccine. That would have been considered unethical for those at higher risk. I think you certainly could argue that if you look at the size of the issue that we're dealing with, it would have been ethical to do it for healthier people. But even if you don't do a controlled trial, at least to have followed a substantial number of people, why did we not follow 10,000 people across the spectrum of society and see their outcomes?
One of the things I started to do in when we had lockdown, had a lot of time, I thought because it was kind of obvious that they were going to bring out a vaccine, I thought I'll just do some research on the current vaccines. And one of the things that I learned, and I spent a long time really trying to search for, and maybe I just didn't find it. So I'd like to hear your thoughts on this. I could not find a randomized controlled trial with a intervention and a placebo group on a vaccine. The trials were this vaccine versus this vaccine.
Against the previous vaccine.
Yes.
With the general result being that the outcome wasn't any worse than
Yes.
the last one.
Yes.
And it was very difficult to say whether the side effects were present because there were side effects with both groups. The statement safe and effective should come with some qualification. I don't think it's been justified at all.
And the justification that they use, which is what you alluded to, was that it's unethical to use a placebo group. And yet, this is a very standard, I mean, it's just with medication, that is the easiest thing to study because you can literally give someone, and it's the same with the vaccine, you could give someone and they would have no idea whether it's a vaccine. You try and do that with chiropractic, you try and do a placebo adjustment on someone, it's impossible. They will know. Which is why it's very, although there's a lot of research in it, it's very hard to really get really high quality evidence. But in terms of medication, you can give someone 2 medications that look exactly the same, but one's placebo and one's not placebo. So why wouldn't you do it in a vaccine just so we can find out results?
Well, the study was randomized, controlled. Some people were getting placebo. That's how they could describe the difference in the symptoms. And that's where they got the 95% outcome from. But because they were so convinced about the results, they unblinded it and allowed the people who had the placebo to then have the vaccine.
Oh, wow. Okay. Yeah, because what I eventually learned, and again, you were talking about this just now, and I learned this from Dr. Asim, who was on Diary of a CEO. He laid it all out to me, and I thought that makes sense because I couldn't understand for years why it would be 95% effective, and yet every single person I know, and I think it's without exception in my perspective, got COVID who had the vaccine, as well as the people that didn't. So I mean, I didn't have the vaccine. I also got COVID, and I was like, how could this? And from that point on, I was thinking, I'm generally not sure if I can trust the research because at that point I was trying to be as biased as I could, or at least give it a chance. And I was like, wow, this is quite impressive results. And then, so then learning that it's actually about relative risk and not absolute risk. The problem is that they didn't make that clear at all. And so the deception to me looks quite obvious. Like I just fail to see how they could have
probably not more so than the rest of medicine's interpretation of pharmacological research.
Right.
It's the trend. That's how things are generally reported.
I see. Okay. Because it's going to favor them more and be able to get the drug out more.
Well, when you see that reduction, there's a natural inclination to think that's that's beneficial. Yeah. But if you just don't ask the question, am I just delaying it by a week or two? And then you won't know the result if you don't ask those questions.
Mm-hmm. So there needs to be more vigor when they're doing the
we need to ask ourselves what's in the individual's interest. And the individual is not really caring that much about whether they get COVID in March or April. They're asking themselves, am I going to have a better quality of life? Am I going to live longer through this intervention? And that's how I think people want to have information conveyed to them.
All-cause mortality rather than a single disease, right?
Yeah. Take, for example, most cardiovascular drugs and the studies on those. They say, well, because we are trying to reduce blood pressure or cholesterol, we're trying to stop you from having a heart attack. Yeah? So we count how many people have a heart attack in the groups who have a drug versus don't have a drug. Yeah? Or we count how many people die from a cardiovascular event, so what we call cardiovascular mortality. Yeah, and what you'll see is that there are advantages in some of these drugs for cardiovascular mortality, but not for all-cause mortality. And that's because some of those drugs reduce your risk of one part of your body going wrong, but create problems with another part of the body.
I think for me, the main issue is the starting point and the logic of it. I think the reason why I don't naturally, some people very naturally will go towards, I want a vaccine, I want medication. For me, I don't, and I think the reason why is because it just goes against my kind of philosophy. So my standpoint is, well, is the body deficient in it? No, okay. So if I'm on that point of view, then I really need to be convinced that this is going to be an overall benefit. As you say, is it going to really reduce my all-cause mortality? So it really amazes me when several patients that have been put on statins just for prevention. And I think that's a different thing. If you have a disease and you're on medication, that's very different too, because they already have a disease. So if you can minimize that, it makes a bit more sense. But when you're doing things for prevention, and I think that's the main issue I have with the vaccines generally, is that we are trying to prevent disease by something that the body doesn't naturally need. And so the other question, of course, which was many people were raising at the time, is why is there not more information on what can we do to be healthier to actually avoid it? Surely that's a better avenue, particularly when you think how much was spent on the vaccines. And then the question of how effective it was.
If we put that energy into driving health, what we could have done, a generational shift in health. But no, that's not where interest was. That's not where the understanding was. Let's see in time whether there can be any shifts there. So it'd be interesting to see in America whether RFK Jr. can make a significant shift in the health policy. He's got the right ideas, but he's up against an enormous lobby. I will be watching that space with much interest.
Yeah, okay. And he is, what position is he in?
So he's he's in charge of the Ministry of Health. I can't remember the terms they've got, but he's got a senior a leadership role.
Okay.
There.
And he has from your point of view, the right ethos about health.
Yeah. I said that before about sort of, best prediction model and seeing what helps you to be healthier. Should people who lead and make policies on things have personal experience and be able to achieve good outcomes? Should the person who determines health policy in the country be healthy? Should they, be physically strong, robust? Should they be linked to industries that are closely associated or very, very financially powerful industries? If you look at RFK, he's in good shape. We can't say that for an awful lot of health ministers.
And am I right in saying that most of them don't have any medical training?
Yeah, most of them don't have any medical training. No. He doesn't either, but he's worked in that industry he was an environmental lawyer for most of his time. And so he's seen the consequences of chronic disease secondary to environmental pollution and the big companies that push back against that recognition.
So before we end, can you tell us what are the top 3 things that you do in your day, the most important thing, non-negotiable types of things that you do in your day to keep yourself healthy at your best and to maintain longevity?
I suppose my diet would be one. I vary what I eat. So sometimes I'll be carnivore, sometimes keto, sometimes low carbohydrate, sometimes enjoying whatever's available. Within that, I will eat a high proportion of animal protein. I probably eat red meat almost every day. It'd be rare not to eat red meat. I eat lots of butter, lots of eggs. We usually have fermented vegetables, usually kimchi, at home, and we'll have that with food very often. Through the winter, there'll be a lot of chicken soup. So that's, for me, get the animal-based proteins as a core part. So I would say 70-80% of my diet is what I called really nutritionally dense food. Okay. And then I'm healthy. I've done a lot of blood markers. I've done exercise tests. I've done MRIs for body composition, done my sleep studies. I'm always working on my own mental and emotional health, and different people will have different ideas about how healthy I am or not in that area. But I feel that there's scope for flexibility at present, that I can enjoy life and be fairly flexible on some things. I think probably long term I'd be better off having a bit more time in ketosis, either through a carnivore or not through a carnivore route. I think the next step for me on that would be to have a coronary artery calcium score done to see whether my family predisposition for heart disease has, combined with my own health, is leading to any calcification in my coronary arteries. I'm 50. I'm about the right time to have that done if you really want to think ahead.
And I was going to ask, actually, because I know you do a lot of testing. So I was going to ask if you've done your blood tests and whether the eating high saturated fats and all the things that a lot of people think that are going to clog up your arteries, whether that's actually the case. So you're saying it's not actually the case and you are healthy.
So I can see from my advanced cardiac profile that looks at lots of different factors within cholesterol that I've got higher familial risk. I do not have the presence of what are called small dense LDL, which is the more dangerous type of cholesterol. And my ApoB value, while high for some people who say you should just drive it as low as possible because you should drive LDL low, when you look at studies that show whether that ApoB level is associated with longevity, it's at the peak point where it's associated with the best outcomes. Mm-hmm. So I'm pretty happy from that side. But having a high blood test value doesn't tell you whether you've got the disease process, absolutely or not. It's usually a more short-term picture. So actually having a scan of my coronary arteries would tell me more. Okay, so that's one aspect. I suppose the other aspect, I spend probably 20 minutes a day or something like that in some form of meditation or self-reflective period or something in that form. That's really important because it also makes sure that I'm making the choices that I want to make in life. And if I didn't have my family and friends, then absolutely my quality of life would be so much worse. So although I'm tempted to say that exercise is very important for my longevity, family and friends trump that by a long way.
And that was one of the things I saw on the Blue Zone study, was actually community was what they had strongly in common. And it wasn't just, which is a bit different to nowadays, actually. It wasn't just, I'm friends with you because well, why not? It was, no, actually, I kind of rely on you because you supply my eggs, or and I supply your meat or whatever. You kind of got that reliance on each other and that interconnected community. And that's one of the things, unfortunately, our society has moved away from, particularly in the UK. I can certainly speak for. Amazing. Thank you so much, Steve.
Thanks so much, Stephen.
Really, really appreciate you coming over, and really, really admire the type of attitude and your belief and your ethos that you have in regards to health. And it's not something that I see particularly within the medical industry or the medical doctors. So it's really, really refreshing. And I think you're doing some fantastic work. And thank you so much for sharing your wisdom and your knowledge this afternoon.
Pleasure chatting with you. Thanks very much.
Thank you.